Hello, and thank you for joining today's All-in-One and One Kit for All, the Benefits of Standardizing Your Workflow webinar. Today we will hear Dr. John Naren, an anesthesiologist from Greenville, North Carolina, discuss vascular access infection prevention techniques and how he and his team maximize procedure efficiencies across CVC, MAC, and PSI catheter insertions in the acute care setting. Secondly, we will hear from Vincent, a nurse practitioner from Rumson, New Jersey, with a diverse background specializing in critical care, emergency resuscitation medicine, and transport medicine. He will discuss how kit configuration standardization increases patient safety and provider convenience. At the end, we will also have a short question and answer section with both clinicians. Now, I'd like to introduce our first speaker, Dr. John Naren, and invite him to turn on his camera. Dr. Naren is a paid consultant of Teleflex Incorporated, and we appreciate his partnership and commitment to bettering patient outcomes. Dr. Naren is a board-certified anesthesiologist. He has multiple publications, presentations, posters, and lectures in the Journal of Pediatric Anesthesia, the Journal of Anesthesiology, the Foot and Ankle International Journal, the FASEB Journal, and most recently lectured in the American Society of Anesthesiologists. Dr. Naren's fun fact is that he was also a medical consultant for a horror movie in 2009. With that, I will turn the webinar over to Dr. John Naren.
Thank you, Michael. Good to see everybody today, and thanks for having me here to talk about the AeroGuard Blue Plus and the Ergo Pack Complete and how it affects my workflow on a day-to-day basis. To start off with, we all know sterile techniques, regardless of the kit. That is going to be your key to infection prevention. You have to remember your fundamentals. You can't skip from the first step all the way to the last step with missing something in between, because if you break sterile technique or have anything contaminated from the get-go, then regardless of what you do after that, then you're not doing a sterile procedure and you're putting the patient at risk. And we all know that putting the patient's well-being first and making sure that we can reduce any type of morbidity and mortality is going to make the patient outcomes better, and it's also going to reduce healthcare costs. And those are the main things as practitioners and clinicians that we're trying to accomplish regardless of what the procedure is. These kits have some great infection prevention features as far as the catheter and some of what the Ergo Pack Complete does. We'll get into some of that in a minute. As well, we're talking about doing procedures. We always want to make sure that we maximize our workflow and efficiencies regardless of what the procedure is. If you get to the point where you're comfortable with the layout, you can be able to use the kit in a acute setting where every second counts. It also makes it, if you need to have a different type of kit for different types of procedures or different types of access, you already know what the kit is regardless of what the catheter is. And then you can also be able to teach your colleagues, students, anybody with you, to be able to provide that for the next generation of practitioners. So getting into infection prevention, the fundamentals are the fundamentals. We have to make sure that we never break sterile technique, because once something is contaminated, immediately the patient is going to be at risk. So that is something that we are going to have to prevent, and the Ergo Pack Complete makes it so we have everything together. But once you actually have your catheter in place, the AeroGuard Blue Plus adds that extra layer of protection to the patient, having the chlorhexidine impregnated in the entire intraluminal pathway, as well as on the external portion of the catheter, all the way up to the external catheter surfaces that is exposed to the air and going to be underneath your tegaderm. That's where you're going to have an issue with biofilms and contamination. So it's good that it's not just the intravascular part of the catheter that is protected. It's all the way up into what is shown on the patient's skin. This has been shown for the central line associated bloodstream infections. The AeroGuard Blue Plus, with many papers, is shown to reduce it 67 to all the way to 100%. So it's something that is well backed up by the literature of making sure that if you have a catheter that has that extra layer of protection and you maintain your sterile technique, you're going to be able to protect your patients from having any type of additional outcomes, especially in the ICU. As we've seen, when you have these infections, it increases morbidity, mortality, and patient costs. And when they've already had other things going on, they don't need to be adding to their acute care issues by having a bacteremic issue. So we have multiple studies, 30 plus, starting to run out of space to put all the reviews and all the research that's behind it. But going into the Ergo Pack Complete system, when we're talking about our fundamentals from needing sterile technique, it has everything in one place. And it's great when you have everything in one place, because you are able to maximize your efficiency and your workflow. You don't have to open up anything additional to put onto the field. We're talking about things like extra chloroprep, your PPE, your transducer cover. All these things are already sterile, pre-filled syringes. There's nothing that you have to add to the mix that's going to just add an additional layer of possibly contaminating your field. When you have this kit, all you need is your sterile glove size, an ultrasound machine, and the kit, and everything else is in there, and it's ready to go. An additional feature is the nitinol wire. It also has a nice advancer that makes it so regardless of what kit that you use, you have the same tactile sense of your guide wire. That makes it so you're not trying to force it through a intraluminal stenotic lesion, and you're going to reduce the risk of having a wire that is retained, which is also another big issue. So going back to some of our maximizing efficiency and the workflow, whenever you have your procedural efficiency increased, it reduces the amount of time in an acute situation where you're able to have access for either resuscitation or reducing the amount of OR time and the amount of anesthesia that the patient is under. So that's going to reduce any type of complications. It's also going to make it so we can reduce the amount of cost in the facility fees. That's something that it should get to the point that the kit is your rate limiting step, and regardless of what type of procedure that you do. And with having the Ergo Pack Complete, and regardless of what type of catheter you're using, if you're already comfortable with the kit, you're going to be able to standardize your workflow. You're going to be able to increase your efficiency, and it's going to make it so it's going to definitely reduce your costs. With the various insertion options, all your components being in one place, it makes it so depending on how you were trained for your ability to enter the vessel and place your wire, you have a bunch of the different type of basic needles, whether it's an angiocath, whether it's a just blunt tip needle, whether it's a needle that is on a guide. Everything is already in the kit, so you're going to be able to use it regardless of what your past training is. Everyone should be able to use the same kit and have those options for their workflow. This is talking about either the central venous catheters or a multi-access catheter, which has some of your catheters for resuscitation, as well as some of your introducer ports, and then the PSI, which is just your regular introducers. It allows you to be able to have multiple different French sizes for whatever the type of procedure that you're doing. So it sets you up for that success to be able to be comfortable with your kit, be able to use your sterile technique, not have to add anything else into the kit, regardless of what your procedure is that you're trying to accomplish. This is in addition to the AeroGuard Blue Plus, which is going to reduce our infection for the bloodborne pathogens. It's proven to reduce costs over and over and over. From my perspective, it's something that it's nice that I don't have to think about my kit when I am in a stressful situation. I'm making sure that I have everything. It's already there. I can prevent contaminating the patient from the time that I place the catheter, and it makes it so that to the very end, I know that my patients have the standard of care when it comes to catheters that are preventing infection. So it gives me definitely a good feeling when I'm knowing that I'm giving my patients the best that there is. Thank you.
Thank you, Dr. Naren. And I'd like to introduce our next speaker, Vincent Fronek, and invite him to turn on his camera. Vincent is a paid consultant of Teleflex Incorporated, and we appreciate his partnership and commitment to bettering patient outcomes. Vincent is a critical care nurse practitioner with a diverse background specializing in critical care, neurosurgical and medical, emergency resuscitation medicine, both rapid response teams and EMS, and critical care transport medicine, both ground and air. And Vincent's fun fact is that he is an avid pilot. With that, I will turn the webinar over to Vincent and invite him to turn on his camera.
Oh, thank you, Michael. Can you see me okay?
Yep, we can see you now.
All right, great. All right, as Michael's introduction said, my name is Vincent Fronek, and the previous slide discloses that I am a paid consultant for Teleflex. My goals today will be discuss the many benefits I find using the Ergo Pack Complete system. Arrow's Ergo Pack Complete system provides a roadmap for standardized procedure approach. The max barrier kits promote reduction in infection without risk or disruption to work. Continued improvement in its engineering provides for ease of use, especially in the details like the nitinol kink resistant wires, the antimicrobial catheters with its intraluminal and external chlorhexidine treatment, all the way up to the hub, assures patients protected from colonization of the catheters. Any institution that's looking to move to a kit like Ergo Pack Complete needs to look to standardize this across their system. I'm a champion of standardization, and I like to improve patient care through that process. I have a very unique background, as already was discussed. So while I'm not the most prestigious critical care provider in the room, especially fellow parents out there, I do have some great perspective with my diverse background. Getting to work amongst greatness provides me with a lot of opportunities to keep learning, so I'm always happy to be the mid-range person in the room. However, over the years, I have evolved into a fairly well-rounded and robust clinical provider. After years of functioning in the chaos of EMS, working as a trauma nurse, later as a flight nurse, and now as a critical care nurse practitioner, I found that I like to excel in critical care procedures and very much enjoy training and instructing the future providers in performing procedures, especially in the emergent and chaotic critical care environment. The unique benefit that I have had over the years is working in the air medical transport environment. This took two of my great interests, medicine and aviation, and intertwined them. Working alongside professional pilots, I learned a lot about aviation, the history, the fatal consequences of mistakes or omissions, and how the aviation industry standardizes its approach through checklists for critical phases, and how they've changed their industry and improved their safety. Medicine has already looked to aviation for improvements, and some branches of medicine have really embraced this approach to safety. Having grown up in EMS and later helicopter EMS, I'm all about preparation and having kits like an airway rule ready for integration or the Ergo Pack kit, which feeds into my love for kits. There, creating a standardization for central venous catheter insertion. It provides a natural flow to move through the process for all insertions, whether they're emergent or we have the luxury of time. The immediate goal is always vascular access, but that's meaningless without the ultimate goal of good patient outcomes, no setbacks, no collapses along the way. While working with amazing professional pilots, I found myself wanting to be more than just self-loading baggage. I began pursuing an interest in aviation. I had a huge privilege to fly friends and family around. But with that privilege comes great responsibility, which I often equate to the responsibility of placement procedures. So I see someone already flip to the next slide. I'll try and be a little bit more brief now that my introduction's over, but the Ergo kit is a way to reduce errors, promote patient safety, reduce delays, and increase efficiency. When we talk about how to improve patient care, we always need to discuss safety. The Ergo Pack kit configuration is a great benefit in the critical care environment. Consensus can sometimes be difficult. Patient safety, and it's important, needs to always be the priority throughout the field of medicine. I'm sure most patients would say their safety is their highest demand. By having all the equipment needed for a procedure at hand, we reduce our risk of errors. Whether a routine line placement or in more urgent circumstances, approaching this procedure in the same way, with the same focus, in the same choreographed dance, without the need to hunt and remember which equipment you need in the heat of the moment, we find less delays and less shortcuts taken. Reducing added stress leading up to the procedure and having the proper kit prepared, we see less deviation from best practice. We increase the chances for first pass success, and we reduce the risk for infection. The right kit means the latest technology thoughtfully built into that kit. There are no doubt amazing providers who can easily hit a curveball or place the perfect sign under not absolute sterile conditions, like in the middle of the battlefield, with nothing more than their MacGyver instincts or skills. But I know the expectations should not make the rules, so we look to the people behind the scenes in the lab, methodically thinking out each step and how it affects the end goal. To perform in the field, we need to take it back to the lab. As a pilot, when I need to perform in the field, I take it back to the simulator. Each time I open the pack, as I do my inventory of my tray, I'm happy to see the best catheters are carefully arranged with its chlorhexidine impregnation to protect the patient long after the procedure is complete. To see the appropriate antimicrobial dressing sitting there for use during my finishing touches, I think to myself, I'm really fortunate that my institution has invested in this workflow and this safety approach. So next slide, just talk about provider convenience. Standardization helps train the future. We keep things calm during chaos. We have all the tools at our fingertips. And with all the unknowns in the emergency and critical care medicine world, it's always good to know your gear. Sure, maybe it's wrong that I think when I'm putting in a central venous catheter at 3 a.m., it'd be nice to have some creature comforts like a well-prepared kit, not having to look through poorly stocked drawers to find what I need. Kind of like my counterparts in the executive world, like my VIP parking spot. I have all the tools well packaged, ready for rapid deployment. This spills over from my medic training days when I was training new medics to go out into the field. They're going out into the field. There's so many unknowns. Your standard heart attack call is not standard. It changes every time. It's always in a different location. There's always different variables. And since even in the hospital, we're not able to control all the unknowns, like what the procedure is, which vessel will be accessing the patient's condition, whether we're in the emergency department, the intensive care unit, the operating room, or on the floor, all these can be different from time to time. It's nice to have a standardized kit that is always the same no matter what venue you find yourself in. This minimizes the unknowns. Also, having the right kit makes training others in the procedure much easier. The kit is designed nicely in a top-down to bottom approach, left to right. It's just intuitive. Even now, when I train people through Teleflex, I find myself with very experienced providers who are maybe sent to a course because the institution's looking for ways to reduce their collapses. And when we break open those kits outside of the hospital, away from the bedside, and we go through them in a methodical manner, I'm always shocked to see how many people didn't know exactly what device was for what and what other equipment is in the kit they never even thought to use. So standardization as an institutional tool for infection prevention, if we approach each procedure in the same way, even the most complex procedure can become a methodical approach, which is well ingrained. The max barrier protection kit is always utilized. Meticulous sterile procedure technique is always at the forefront of our mind. The appropriate dressing is always placed. The appropriate catheter agreed upon in your institution is always in the patient. The evidence about chlorhexidine protected or antimicrobial catheters is apparent in every literature you read, and we should be looking for the long-term protection of our patients. Many providers will tell me they're already very proficient in placing catheters, but why should one patient be lucky to get you as their provider but another patient down the hall is getting a different provider. This is why adopting a standardized approach gets the same equipment and the same procedures to all the patients, and thereby reducing the risk of infection throughout the institution. I'll excuse myself if any of my data is outdated, and feel free to email me with any sources or updates if you have them. But the data just I'm using here is to prove a point. The estimated cost of eclampsia alone should have institutions easily investing in and placing as many resources at the bedside as possible. I think the most recent CDC data shows the good news is eclampsia rates are down, but the risk of getting eclampsia could still cost an institution $45,000 per case. Again, I'm drawn back to my aviation passion, and I think of the numbers, which are a little rough here. But according to the Joint Commission in 2012, 250 eclampsia infection cases are found, and about 25,000 are associated with deaths. That year, roughly 5 million lines were placed. It's about 5% get an infection, or 0.5% die. That's 68 people per day. If I compare that to the number of people flying, about 2.9 million people fly every day. That'd be about 145,000 people injured, or 14,500 deaths. I don't think anybody would be flying if that was the case. It doesn't make you want to sign up for a potential eclampsia or central line infection. So everything you need all in one place. That's why I love standardization. Whichever invasive line you need, the kit is like a checklist. As an aviation guy, I think of ways medicine has taken from aviation to improve safety, like how anesthesia and surgery has started implementing checklists, cross-checks, and standardized approach. There's a standardized procedural timeout before every procedure. Utilization of a standardized kit also can help assure no patient is hearing anything awkward while they're awake, like their provider asking for equipment not readily available. Just like you don't want to hear your pilot saying over the intercom, man, I wish I had some flaps for this landing, which, unless a rare mechanical failure happens in flight, this doesn't happen because of pre-flight checklist. You also don't want your procedural scaling for supplies while they have a needle in your neck. Think of what it'd be like to hear, where's my guide wire? Someone get me a guide wire. As a layperson, I'd be thinking, guide? Wait, why does this person need a guide? Don't they know what they're doing? I like to think of a well-designed kit as your pre-flight takeoff cross-check list. While dealing with a complication, not having to ask others for equipment or potentially contaminating your sterile field or creating more complication is nice. One great new tool I've been enjoying is in this kit is the nitinol kink-resistant wire. When you find yourself in the although rare but inevitable complicated placement, it's nice to have your equipment not fail you. A kink wire can lead to delays or unsafe troubleshooting. Also, the unique biofeedback of the device through sterile gloves provides small creature comforts that make placing a line a potentially dangerous or complicated procedure even easier. So any way to have well thought out tools in place to help make the process smoother is a great benefit to the provider and more so the patient. Ergonomics, the study of efficiency in the workplace. It's fun to be a silent observer in a hospital. Much potential is always seen. Having a well-designed kit developed leads to better efficiency during line placement, which decreases risk of potential safety events. It is truly everyone's job to get rid of eclampsias in this world. While zero could be argued to be a utopia, we should never stop striving for improved outcomes. We all hear the number counters and the stats or the bottom financial line. Yes, we know on average the eclampsia cost is $45,000 in lost revenue, increased length of stay for patients, and increased cost of treatment. But as providers, we see how much infections change outcomes and cause suffering. Most eclampsia infections potentially occur during placement. This tool, this Ergo Pack Complete, reduces the breaks in sterility and improves the patient's outcome. So our immediate goal, remain focused on the task without becoming saturated or overloaded. Overall goal is to use standardization and checklists to improve quality and efficiency. Especially in less experienced providers, it's easy, especially when they become task saturated, to become overloaded with tunnel vision on the immediate goal of this patient needs this central line. It is my job to place this line, and the novice can miss the overall goal. The person's critically ill, and the overall goal is hampered by a line infection. So we train our critical care providers to remain task-focused, but with the overall picture in mind. Task saturation is a huge focus in the aviation-related incidents and is based in the idea that each of us has a limited capacity to process, with each person varying in that degree. It's reckless to think one is invincible to being overwhelmed. Yes, a bedside procedure can be routine, but so can landing an airplane. However, there are times that this procedure may be performed in stressful scenarios. Think landing a plane in bad weather or placing a central venous catheter in an emergency. Each passenger on this plane expects the pilot to land the plane, so why shouldn't each patient have the expectation of successful procedure without complications? In aviation, pilot workload is reduced by eliminating tasks to focus on priorities. In medicine, we too should eliminate tasks. What do I mean when I say we should eliminate tasks? In aviation, the adage is aviate, navigate, communicate. So don't worry about talking, you need to fly the plane. And utilization of automation like autopilots will reduce workload. By using well thought out pre-planned kits like the Ergo Pack, proper training and standardization, we can remove tasks leading up to the procedure so we can focus on the procedure. No hunting for supplies or hitting roadblocks when an essential supply is missing. You look down at your kit and its arrangement becomes your list. The best catheters in place, the right dressings there too. Additionally, the unique lessons we learned in the most recent pandemic during longer courses of ICU care, longer line placements, extremely sick or medically complicated patients, the unknowns earlier in the pandemic about transmissibility and clinician exposure, all added to the stress of the providers placing lines, more distractions, more unknowns. The complicated infectious disease management of these patients and immunosuppressing them during their treatment, all while hoping not to give opportunistic infections, makes antimicrobial lines and mechanisms in place a top priority. On top of it all, we saw periods of tremendously larger volumes of critical patients remaining in lower tier critical care centers, and many places asking people to quickly step into new roles, all showing that a standardization process helps when situations become not standard. Excuses aside, even if there are really good ones, excuses aside, even if they're really good ones, with all that we have learned in the management of complicated critically ill patients, infection prevention has to remain paramount. We all know the rule of thumb, do no harm. Everyone has that right. So we all continue on with the goal to zero collapses. We do so by putting systems in place, using the best products with supporting evidence and data. Any institution who has started the process of antimicrobial stewardship should consider removing risk of infection, especially during the placement of catheters, and utilizing systems that have antimicrobial catheters, which have shown to decrease the colonization by up to 99% for up to 30 days. Eliminate the host from being exposed to infectious pathogens, especially those hospital-acquired and difficult to treat ones. We keep asking ourselves, what's the best way to get to zero? Testing the hypothesis, following the data, and implementing processes like the newer cool technology that we've already discussed here today. There's a whole host of third-party societies and organizations that support this idea. With intraluminal antimicrobial throughout the entire fluid pathway, the internal parts of the catheter provide added protection, and additionally, the exterior of the catheter all the way to the hub is treated. So even where the catheter exits the skin, all the way up to the hub, has added protection to protect the patient during times of dressing changes. So long after placement procedure, you're still protecting your patient. We have already discussed heavily how a prepared kit, like the Ergo Pack, helps with efficient procedures and can act as a checklist to prompt the provider not to skip steps. This improves outcomes and streamlines the process. It reduces harm and decreases error, gets the job done quickly, increases first pass success with reduced complications, all while maintaining sterile procedure and the ability to maintain best practice. Standardization, it cannot be emphasized enough. Yes, medicine cannot be standardized, which makes the entire field unique, but procedural areas of medicine can in order to improve efficacy and safety. Having what is needed at the hands of a skilled provider adds benefit for patients and also convenience to the provider and also to the instructor while training the new provider. By creating a natural flow that with repetition makes the process a more seamless event, reducing distractions, contaminations, or complications, an Ergo kit can function much like a built-in checklist. Personally, I do a lot of training. So after infection reduction and creature comforts, I think of how tools can be used to educate the future providers. I call the Ergo Pack the newbie cheat list. Not only does the kit come with a checklist in the paperwork on the outside flap, if you don't know that already, take a look at all the valuable information provided in the kits. But also, if you unpack it properly, each step and each item you come across prompts you right down to a towel strategically placed on the top of the kit to remind you to wash your hands. Infection prevention starts before the procedure. Once we have these best practices well choreographed in the lab, every show, no matter the venue or the performer, should be similar. No matter if you're in the ER, the ICU, or the OR, who the provider is, we should all be using the best standard approach to increase confidence in not only line placement, but also the line will not become a complication for the patient. With a standard approach, yes, the situation might become more urgent, but the procedure and the steps are all the same. And following a streamlined, efficient manner, comfort can be found in the knowns while handling the unknowns. Let's finish with my love for aviation. Yep, I think I'm becoming that guy. When you have a passion like aviation, you equate many things to it. Where I do not need a checklist, I sure do use them for cross-check to keep me honest and to keep my family safe. I promote other concepts of aviation, critical phases of patient care, like intubation procedures. I promote sterile cockpit, but just a little humor before I leave you. Sure, anyone can land a plane, but the good pilots understand the real assignment, land the plane in a condition that it can take off again. So we should place our central venous catheters in a manner that leaves patients able to take off again. All right, thank you for your time.
Thank you, Vincent. To the audience, here are the references utilized within today's webinar presentation. Thank you again, Dr. Naren and Vincent. We're now going to begin answering the questions submitted during today's presentation and prior to the webinar. For the audience, as a reminder, you can still submit questions through the questions pane on your screen highlighted here. I invite both presenters to turn on their cameras, and our first question is for both presenters, and we'll start with Dr. John Naren. Your question is, you mentioned retained guide wires briefly. Can you walk us through what happens when there's a retained guide wire and how to mitigate that from happening?
Luckily, I've never had a retained guide wire because have been lucky enough through my training to use these nitinol type of J wires. However, I have felt in multiple different occasions, actually last night and this morning was one of them, where there was a patient that had some previous central access, and you could actually feel a little bit of resistance with the nitinol wire. And then by rotating it, you could actually get around the stenotic lesion. If I ever had a retained wire, the first thing I would do is just, well, if I felt like something was caught, the first thing I would do is just place very gentle traction to see if I am just caught up on something that the wire would be able to get around. You don't want to manipulate too much. If you're caught on a plaque, then you have a chance to have an embolic event by you throwing a clot off. If it got to the point where I was putting, and usually what I do on any type of procedure, if I know that I'm putting too much of pressure on it, either the wire will start to tent or the skin will start to tent. If I had that issue on a patient, at that point I would stop and I would probably consult vascular surgery, because you don't want to cause either an aneurysm, pseudoaneurysm, like I said, an embolic event. So you want to be very careful with if there's something that is retained by causing more problems getting the wire out, by then just leaving it and doing it under a more controlled type of retrieval process. But that is why the retained wire is preventing it is so important with a nitinol type J-tip wire, something that's going to be soft enough that it's not actually going to make a false lumen go through the vessel, those sorts of things. It's just talking about it, it sounds like a situation that I really don't want to get into, having to retrieve a wire.
Thank you, Dr. Naren. Vincent, same question.
Yeah, I would say I too have been fortunate to have never had to deal with this emergent situation, but obviously it's been a historic concern, and it's presented each time I am teaching a new course on central venous catheter placements. I think I've discussed pretty heavily on standardizing the approach to the procedure using organized kits to make sure that nothing is retained after the procedure. I think Dr. Naren discussed very effectively there on the complications of having the wire become stuck or retained during the procedure. Using good skill set, if you do hit resistance, removing your needle at the same time as you remove your wire so you don't accidentally shear the wire with the needle tip if you're trying to remove the wire. Obviously a vascular surgeon consult is imperative if this becomes an ongoing issue that's not able to be troubleshooted. I think in modern times, though, as we continue to train our new providers through the use of ultrasound as it becomes the standard approach, the wire, with needle puncture under ultrasound guidance and watching the wire into the lumen, the wire really shouldn't be forced into blind spaces or blind pouches. Maybe it's a historical concern. And I don't have a lot of experience with it happening in my practice. I think it maintains itself as a fear of providers, and it's a complication that needs to be discussed when training new providers in this procedure.
Thank you. The next question is about catheter placement location, subclavian IJ versus femoral. And Vincent, we'll start with you on this one and then go to Dr. Naren. How do you decide where to place your central line?
Yeah, this is actually a pet peeve of mine. I feel like as we train more and more providers, ultrasounds become the dominant force. Everyone is quick to race to the easiest, largest location. The right IJ has become pretty prevalent. And if you look at some of the data, everyone poo-poos the idea of the femoral line, but a lot of the data with infection risk shows that there's possibly an even increased risk of infection in the right side of the neck. And also with my experience in the neurocritical care area, I've worked with some neurosurgeons that request politely, if they're taking their patient to the operating room, that the neck left preserved for the OR. So I have become proficient in the subclavian approach, and it became my preferred approach. I enjoy training new providers in axillary approaches using ultrasound guidance to remove some of the concerns that come up about pneumothoraces and dropped lungs. But I think what we really need to start expressing is, yes, I don't ask people to do procedures they're not comfortable with, and that should never be the case. But the right placement should have to do with the patient, and it should be correct for the patient, not provider convenience. So all those sites that you said in that intro question are appropriate at different times. My one example would be my neurosurgical example.
Dr. Naren, same question. How do you choose where to place your central line?
Well, like Vincent was saying, the neurosurgeons won't have them, when it's not in the OR, do things on the neck, because I'm the one that's guilty of, I have the area that's for my convenience. So yes, Vincent is completely right that it has to be for the patient, for the procedure. You want to make sure that you do the correct thing. Classically, subclavian number 1 with IJ2 and femoral 3 is your infection risk from lowest to greatest. But with these new catheters, we're seeing the femoral is not quite as big of an infection risk when you start having the AeroGuard Blue Plus type of catheter that's impregnated with it. So that's one thing that, if you definitely need a leg line, you can do it and not be as concerned with infection risk, but I will certainly say that I'll admit that I'm guilty that if I have a choice, a lot of times it is the right IJ for me, mostly because during the procedure, if it is an appropriate procedure where I can get to the neck, I can get to the lumens in an emergency a lot quicker. I can resuscitate the quicker that I can get to the line, and the closer that I can give the fluid to the patient. Usually if it's a subclaving, it's depending on the procedure, I may or may not be able to get to it as easily. And then the femoral is obviously going to be a little bit further away from me. So I kind of use a little bit of a hybrid approach for, it's not really my convenience, I guess. If it's something that's going to be closer to me in an emergency, it is convenient, yes, but it is something that there's some reasoning behind that.
Yeah, I would say in an emergency, obviously the patient's best interest there is that you get emergent access. So I support that completely.
Get as close as you can.
My preference in an emergency has just always been the left subclavian being right-handed dominant. In an emergency, there might not be an ultrasound available. A lot of people feel most comfortable going to the femoral. So when I say provider preference, I just am criticizing the people that think only the right IJ is able to be accessed.
Yes, be flexible always. That is key.
Thank you both. That was great. And if there's any additional questions about that, feel free to put them in the chat, questions box, or email us after the webinar. So this one is an interesting one. So it says, you spoke about all the different components within the kit. One thing that wasn't mentioned was the dressing. We are currently in an evaluation for both BioPatch and Tegaderm CHG Ergo Pack Complete kits, and are going to move forward with the one that performs the best, both from the ease of use standpoint and for our clinicians. Dr. Naren, we'll start with you. Which dressing kit do you prefer for Ergo Pack Complete, BioPatch or Tegaderm CHG, and why?
I like the Tegaderm. I haven't used it that much in my practice. I've only used it actually at the Teleflex Academy. I would probably like to get that because it's just one less step. It's all one piece. Sometimes the BioPatch, if you don't actually have the dressing up close and correctly at the hub site, the BioPatches can sometimes have a tendency to either come off or rotate. At that point, you would either just replace it, or with the whole Tegaderm piece, it's just one kind of piece of goo. Like Vincent said, I like less steps, and even if it's a couple seconds, and then the end that adds up. And if in a critical situation, if I need to put on a dressing that's sterile and not have to, move on to the next step for resuscitation, any kind of time I can reduce the step, it's always better.
Vincent, do you agree?
Yeah, I absolutely agree. I think I mentioned it briefly in my talk. Obviously, I think I'm also a little bit long-winded, but when I open up my kit, I like to see my appropriate dressing based on my institution's preference or what the data shows is the best device to be using. I have a preference towards the chlorhexidine impregnated dressings. The BioPatch, I've used it tremendous amounts of times in my career, but it's just another device that could fall off of the field and become contaminated and delay finishing a procedure. I think the most important thing is properly placing whichever dressing you're using with all of its mechanisms in place to protect the patient and to reduce unnecessary dressing changes and to promote max infection control at the site. So I don't have a strong preference, but if I was asked to make a decision, it'd be the chlorhexidine impregnated Tegaderms.
Yeah, thank you both. And we have a comment from Connie. She says, we prefer CHG Tegaderm because the dressing is transparent where the BioPatch is not.
Yep.
All right, so I think we have time. We're at 45 minutes for one more question. And this is, I think, a simple question, but I'd like to start with you, Vincent. How do you know that your catheter is protected with chlorhexidine? We are looking to change to a protected catheter, but how would we know? That's the question.
I can speak to the Aeroflex or the telephone catheter. The blue coating on the catheter lets me know that I have a antimicrobial protected catheter. Also, the IFUs in the kit, on the outside of the kit, I mentioned in my talk that there's so much information in there that a lot of people just kind of breeze right by. but especially, in the early days of using these kits and when you're training new providers, it's a good thing to break it open and learn what your institution's using, so you're not making any assumptions in the level of care you're providing. And if you see a shortcoming in your clinicals, you have an opportunity there to improve the system and improve the patient's care.
Dr. Naren, same question. How do you know that your catheter is protected when you open your kit or when you're choosing new kits?
I always, just like Vincent said, I always look for the blue. And if the catheter is blue, it's going to have the AeroGuard Blue Plus, so there's not really any question.
On behalf of Teleflex, thank you, and thank you to our presenters, and have a great rest of your day.